Hey, everybody. Good morning. It's John here. Welcome to another Virtual Morning Report episode. I get to be co-discussing with Valerie today, and we have Jillian doing first teaching points for the first time, or scribing for the first time. Unmute and say hi to everybody.
Hi everyone, I'm Vale, joining from Lima, Peru. I'm really excited to be co-discussing with John today, kind of jump in the last minute and I know it's not going to be a neuro case today, so bear with me. It's not my forte, but really excited.
Hi everyone, I'm Jillian. I'm doing teaching points. I'm doing scribing. Excited to be here.
Cool. And thanks, Ravi, for sharing part of your great case library with us and preparing for this at the last moment. Appreciate the flexibility.
Oh,
So,
yeah. Very happy to move over to the presenting seat. So I have a great case and allowing a lot of our CPS members to bask in the limelight and discuss a case. And then lastly, we have Eugene doing teaching points. Oh, Eugene, we can't hear you.
well, anyway, I wanted to say that anyone in the chat who wants to contribute to discussion,
Hello.
always welcome to unmute and join in as much as you're comfortable doing. And I think it looks like I got the audio visual working, so I'll pass the mic to Eugene to say hi.
Go ahead, Eugene. You're muted still. Still not working. Okay. Yeah, Eugene, work on so you probably have to choose the mic on your computer.
Yeah, can you hear me now?
Oh, okay, we can hear you. Yeah.
Okay, sorry about that. So I'm Eugene. I'm a doctor from Ghana, and I'm excited to be doing teaching points. I just want to say thank you again to Dr. Ravi. He's the main reason why I was able to join this academy. So whenever I get a chance to share space with him, I want to say thank you to him. And I'm excited that he's presented a case and I'm doing a teaching point. So thank you.
Thank you, Eugene, for those very kind words. But without further ado, let's get into the case. So today's case is a 58-year-old male who presents with the chief complaint, chest pain, 9 out of 10, constant, substernal, crushing, non-radiating. And he also has shortness of breath, cough, yellow phlegm or sputum for 10 days. And I'll stop there for discussion.
Okay. I guess Valerie, you can feel free to take the first pass with the chief complaint in one-liner.
Yeah, so I think I'm gonna lay like some basic thoughts and you can layer on them with your expert opinion. So yeah, I think we have a middle-aged man with some really classic CPS complaints, chest pain and shortness of breath. And the chest pain, I think, as we have discussed many times before, we have to prioritize, like things that could be deadly for the patient, and like for things really come to mind. And that can be divided anatomically from like the heart first. So like an MI is something that we would be really concerned in this patient, but also something like a tamponade could cause chest pain and shortness of breath and can be deadly. Then going to pulmonary causes such as a PE or an effusion or pneumothorax, which is more like an acute emergency as well that can cause chest pain and shortness of breath. And then the third anatomical category that comes to mind, and isn't something that I try to remind myself always, is the esophagus that can also present with shortness of breath. And layering on that, I think we have some signals that, make me think, okay, is this more likely a heart or a lung problem? First, I think the intensity makes me worried about a heart issue, and the fact that, at least from my first impression on the one-liner, it seems to be quite acute. So of course I would like to, get an EKG and some troponins. The shortness of breath doesn't really make me think about the lung or the heart more, or the other way around. But I think the cough for the last 10 days could be a point. Okay, could this be more like a lung problem? Like, for example, someone is really coughing and then they have like a pneumonia or something, and they develop like a pleural effusion that can cause pain, or they're coughing so hard that they just pop like a bulle and they get a spontaneous pneumothorax, without really forgetting about causes that can be post-infectious or peri-infectious in the heart as well, like myocarditis or pericarditis, that can be really easy to miss. So yeah, those are my first thoughts. Would love to hear what you think, John.
Yeah, great job. Hard to add too much more to that with the amount of data we have right now. But I'll just highlight some parts. Is that I love how we're kind of in the first pass, we're really kind of, practically speaking, we're focusing on the life-threatening causes. Getting ECG is oftentimes on your desk before you even get the full interview of the patient. And then like I do like to run those, like the DDX of the most life-threatening causes through my mind, just to refresh my memory before you go interview the patient, so you can do a hypothesis-driven history and physical after you've let them kind of tell their story. I remember like just when I was a trainee, getting some feedback, I tended to go to the jugular with my hypothesis questions too early before letting the person share and kind of tell you more of things you wouldn't maybe think to ask them. So that's where my head's at. So I'd like to rule out the life-threatening things that you already discussed. And this cough with phlegm for 10 days, there's some folks have already hypothesized about respiratory issues secondary to cardiac with pulmonary edema or post-infectious sequelae. Somebody had an infectious pneumonia with consequences of that they're now dealing with. But certainly that description of the chest pain makes ACS and kind of excluding that possibility the forefront of my mind before I even can think too hard about other things. So it's like before I see the ECG, it's like I can't even entertain other things that heavily yet. So let's see what we get next.
Awesome discussion so far, both of you. So more background on the case. So the patient came back from a cruise 10 days ago, tested positive for COVID with home testing, wasn't feeling well, especially with the cough and yellow sputum. Also reported dysphagia and weight loss, 10 to 12 pounds in the last 1 month. There is no PND, no orthopnea, no leg swelling, no nausea, vomiting, no abdominal pain. Also went to an urgent care and got prescribed doxycycline for possible bronchitis. Yes, I'll stop there for discussion.
Go ahead.
Sure, I could do the quick first pass on this one. So the new most relevant data summarizing is we had a recent home test COVID diagnosis. This kind of a quick weight loss and dysphagia of 12 pounds over the last month. So I will try to see if there's a way we can tie these things together. If presuming with COVID, complications we sometimes see of that, it's well known at this point to be a prothrombotic state. So it's another thing that would, somebody's had a recent COVID infection amongst the life-threatening etiologies, putting a little bit additional weight on just making sure you've ruled out pulmonary embolism. And the duration of the symptoms, it's persistent. Sometimes after any viral infection, the cough can linger for a while, but it seems like it's not really improved with doxycycline, which wouldn't be the first line treatment in and of itself if we were treating for a community-acquired pneumonia, and most bronchitis is viral anyway. But the weight loss in the dysphagia is very concerning. And I'm just trying to think of ways to tie these two together. Could there be another more subacute to chronic process in the background with now acute respiratory problems perhaps related to the COVID and complications from it? When I'm thinking about dysphagia, I do try to through the history, there's a lot of you can ask them questions to try to tease out if it's more of an oropharyngeal or a esophageal process, like if they're having reflux, if they're having whether it's progressed liquids to solids from just liquids to everything. So let's try to tease that out more with the history, and I'm still in the mindset of ruling out the life-threatening causes. Vale, what do you think?
Yeah, and I love all your analogies. The jugular one especially because I actually use it a lot with my friends when we ask like a juicy question. It's like, oh, you're asking me a question to the jugular. So yeah, but I never use it in like the patient setting. Okay, so yeah, I totally agree with what you said. I think the dysphagia is tricky with the weight loss because I don't really know if I should be like, okay, is the weight loss like a sign of something like more inflammatory but longer going in the background, or it's just like a consequence of the dysphagia itself? And I totally agree. We could do more questions to kind of see where in the anatomy of the GI tract we are located with a dysphagia. Nevertheless, I would still go for an HIV test, honestly, on a patient that has like weight loss and new respiratory symptoms like possible pneumonia. Then with the cruise fact, I don't know if that's a red herring, but I think, cruises have some factors that may predispose someone to like some certain infections. Like, for example, a lot of cruises have um, like air conditioning or whatever, like things that come to mind maybe like Legionella, but we don't have like GA symptoms, but something to keep in mind just as we probably are gonna discuss soon about antibiotic coverage. But I totally agree. I think at this point we're still a little early, and I would really like to rule out some like more emergent causes of chest pain and shortness of breath.
Absolutely wonderful discussion. I love that both of you are have elaborated on a lot of these thoughts. So moving on to the next part of his history, so past medical history, high blood pressure, hyperlipidemia, and then medications, amlodipine, HCTZ, atorvastatin. No family history, but personal history. Smokes 1 cigar per week for the past 5 years. 2 beers per day for about 10 years. No substance use. Quite active, 9 to 10,000 steps per day. And moving on to physical exam is blood pressure, 94/37. Heart rate, 203. Respiratory rate, 20. O2 sat, 99 on room air. And temperature is 37.2. General is looks critically ill. Cardiovascular, regular pulse. And the chest is tender. And lung exam, decreased breath sounds, especially right side, is labored breathing. And I'll stop there for discussion.
Okay, yeah, John, I can start with this one. I got a little tachycardic myself when I saw the heart rate of this patient, and also the blood pressure. I think, with the past medical history and the age of this patient, even though we are still technically on the systolic normal, but I will still consider like hypotension, given that probably his baseline is higher. And we have a very high heart rate with an irregular rhythm, which of course makes me wonder, okay, is this patient having like AFib or a flutter or and an EKG, I think, will be important in this patient, of course. Before I kind of, my reflex will be like, oh, we have to like control this rhythm or whatever. But I think we recently had a session on the academy where we discussed about how, patients with AFib and a flutter, concomitant with hypotension, that should really signal to you that this heart rate is, a response most likely to something that is causing the hypotension rather than jumping in and like controlling the rate, because that would worsen the hypotension. So yeah, I'd be concerned about why this patient has such a low blood pressure. Given the history that we have, I'd be concerned if something like an MI is still going on, probably an EKG and troponins will be imperative here, but also an infection like a pneumonia or a myocarditis, which can also be a complication of COVID. So yeah, those are my initial thoughts. What do you think, Young?
Yeah, so really concerning situation here, isn't it? With it wasn't quite what I was expecting on the exam. So we have like the big highlights, a very, very sick looking person whose heart rate is north of 200, blood and they're they're hypotensive with decreased breath sounds and respiratory distress. So it's like if I'm seeing them, like if I'm not used to being in the emergency department. So if I had somebody like this on, that I'm taking care of on the floor, otherwise I would, from the first things I would do would rally the troops in whichever way you do on the floor. We'd call a rapid response, or in the emergency department, gather up the help that you need for the possibility that this person could in the near future need a synchronized cardioversion for a presumed tachyarrhythmia with hypotension. So really curious to see what's on the monitor and what's on the ECG. But for I think a common algorithm is like if the unstable tachyarrhythmia may end up needing a synchronized cardioversion. That's the problem. It'd be a little surprising for like if it was like sinus tachycardia from whatever underlying problem is to be going quite that fast. So it's striking me as a little bit fast for sinus tachycardia, but we need to really urgently want to see what's on that monitor. And I'm also dissecting the background a little bit too. We have some kind of subacute to chronic process, and I'm thinking about, is this progression of this underlying chronic process, or is it something that was a risk factor for what's happened? We have a couple of risk factors for things like ACS, for cancer in the backdrop. But what's going on in the foreground, I think, like the decreased breath sounds on the right, and a patient who's unstable and in respiratory distress, you have to consider the possibility of a pneumothorax. Like if somebody's had or some kind of complication of they've been coughing from a viral infection, and you have like esophageal perforation with a pleural effusion. So yeah, this person needs a high level of care. If they're like in the emergency room right now, hopefully you can pretty quickly rally the troops and get this urgent situation taken care of, whilst we get more clarity on what happened to them, and the ECG and the quick X-ray, whilst calling a rapid response. That's where I'm at right now.
Absolutely wonderful discussion so far. Again, just to shed some light, Richard in the chat's asking, wonder why he went on a cruise in the first place if he had dysphagia. So it was intermittent dysphagia. So on, I'll go with the labs first, then we'll go through the other tests. So the white count was 23.26, so 23,000. Hemoglobin 11. And predominantly neutrophils, 86%. Platelets normal. And chemistry was normal. Troponin, yeah, chemistry we can keep it normal. And troponin initially 14, 15, and then climbed to maximum 1760. EKG showed atrial fibrillation with rapid ventricular rate. And the rhythm was addressed with diltiazem. Initially, the blood pressure was better at that time, and the blood pressure was after the diltiazem, and amiodarone drip. And then the subsequent EKG showed diffuse ST elevations, no PR depression, and the ST elevations weren't, I don't have, well, the ST elevations weren't specific to a geographical location. There weren't reciprocal ST depressions in the other leads, so just diffuse ST elevations. And I'll stop there for discussion.
Okay. So I think, once we rally the troops, sounds like just kind of repeat the blood pressure. It's doing a little bit better. And the atrial fibrillation, I'm now kind of thinking about it as probably it's a kind of it's a consequence of whatever of the underlying process that's causing this patient to be so sick and to have a significant neutrophilic leukocytosis. So when we see like the diffuse ST elevations on ECG, some of the reflex thoughts in the context of somebody else who's had a presumed recent viral infection could be a myopericarditis, and considering possible complications of that. The troponin bump is pretty impressive. I shouldn't call it a bump, like a pretty significant rise. And when the troponin's elevated, we're always some of the first reflexes, like, is this representing a evolving acute coronary syndrome? But also can be plenty of other things can cause an elevated troponin, but that's the default assumption until you've excluded it. But a myocarditis could certainly cause a pretty significant troponin, especially it's been dealing with increased demand from atrial fibrillation. But I try to ask the question of, like, is the amount of troponin elevation proportional with the demand that's happened? Somebody who was in a heart rate of 200 for uncertain amount of time, but it's it's a pretty significant elevation for me to just chalk this up to demand, especially with that ECG. And so where am I looking at to make progress here? Certainly would be trying to expedite getting chest imaging, echocardiogram to try to assess, are there any wall motion deficiencies? Is there any pericardial effusion? Is there any valvular problems going on in the back? And I think so X-ray, echo. Let me turn the mic to Vale for some more thoughts before we get more information.
Yeah, thank you, John. That was brilliant. I totally agree. I think the first thing that comes to mind with diffuse ST elevations is the pericarditis or myocarditis, especially when we have a patient like has had COVID or is having COVID. I have a question because I really don't know, but if you were seeing this patient in real life, given that, I mean, I know pericarditis can present with like chest pain as well, but I know that some diffuse ST elevations can also be seen in like multi-vessel occlusion. So would you like to go to cardiology or to interventional cardiology to see, like, to expedite some more invasive vessel studies, or would you be confident like pursuing other type of chest imaging first?
I think, like, with somebody who's striking me as this sick with the ST, even though the ST elevations don't map to a coronary distribution, with just the height of the troponin elevation, ST changes, the crushing chest pain. Let's say I'd be doing, whilst I'm doing my treatments, ordering my next test, I'll have one hand on the keyboard, one on the phone, calling cardiology to come be part of the team, look at this ECG, because I'm typically not the one who personally decides to activate the cath lab, but I would definitely involve cardiology, very early on in a case like this. And yeah.
Thank you.
All right, very good. I'll show the initial X-ray. Oh, I think a request has been sent. Okay, there we go. So I'm going to show the X-ray. Are you able to see the screen?
Yeah, you can see just like a little bit, it's a little bit small, but I can see it.
Yeah. I maybe can get a crack on some like initial impressions of the chest X-ray. I mean, my first impression is, okay, heart is a little big. I also see the right diaphragm to be elevated, which to me would suggest something that is pulling it, such as like an emphysema, or I've also seen it like some consolidations that can do that. And well, more rarely if there's something like neuromuscular going on, just to like mention something neuro-related in this case. And then I see some like maybe like cotton wool spots around the like the mediastinal region, some congestion there. But otherwise, I mean, I think what really strikes, I mean, we were thinking, okay, like emergent causes of chest pain, we don't see a pneumothorax. I don't see any signs of like a pneumothorax, at least. I don't see, air in the mediastinum that could suggest like an esophageal rupture, which was another thing that we were entertaining. But I do think that maybe the next step will be like an echo to see if there's some fluid in the heart, because it's a little big. What do you think,
Yeah.
John?
Yeah, I'm thinking it like doesn't look as bad as I thought it was going to. So like that's all this like does this X-ray explain the whiteboard over on the other side, sufficiently? It's like we were talking about like this person, we entertained things like esophageal perforation, or maybe they developed a pneumonia, had a big loculated empyema on there. We're not really seeing, and at least just kind of from my like zoomed out view, I don't see like a big pneumothorax to explain respiratory distress, decreased breath sounds. So I agree, it's like that the right hemidiaphragm is higher than than perhaps it would ordinarily be. That right hilar area looks kind of crowded. So whether there certainly could be some opacity in that region, but yeah, I think the big thing for me is like, it doesn't look as bad as I thought it was going to for somebody who was coming in this sick with a white count. I thought we might be seeing some sequelae of like an empyema or I don't see any like wondering, like I'm trying to see like, is there any pneumomediastinum? There's like this little like area of black like on the like right side of the heart, but that'd probably be an overcall on my end. I don't see any obvious air.
Yeah, you're correct with that. So the reading was slight prominence of the hilar region, which might present as lymphadenopathy, mild right infrahilar pacification, could be airspace disease, and need to follow up with maybe a lateral view to rule out malignancy.
Yeah, I think with the smoking history, like certainly have a low threshold to get just to better understand what's going on in this space, to even just kind of quickly go to like a CT scan of the chest to better evaluate. At first, we were wondering, like, is this like something bad happening in the lungs that made the person sick, and then they had AFib with RVR and cardiac consequences? But the X-ray is kind of unimpressive. The saturations are 99 on room air, and so like I think like just now with those two, like the center of gravity is going a little bit more towards the heart.
Moving on to echo. So mild LVH, EF greater than 75%. Small pericardial effusion anterior to the right ventricle. And then since the troponins were elevated and with the EKG of these diffuse ST abnormalities, a cardiac cath was done. And there was a clean, I would say clean cardiac cath at this point. So there's no targets for PCI.
Do you want to take this one first, John?
Sure. Yeah. Oh, like, was there any was it pretty no wall motion irregularities, or I mean, it was just the small pericardial effusion? Is that correct, Ravi?
Yeah, you could say there's it could be an inferior apical wall motion abnormality, very mild, but LVF was fine. Otherwise, yeah, no targets for PCI.
Okay. Yeah, with that, so with this kind of clinical scenario with no PCI targets, question mark, like apical abnormality, and some of the first things, like what am I looking for in the echo? Make sure there's nothing catastrophic, either with wall motion abnormalities, consequences of ACS, the mechanical ones that can happen if somebody's presenting after a serious MI. We're not really seeing signs of that. I brought up pulmonary embolism early on, just given we had a story that sounded kind of concerning for the possibility of malignancy with dysphagia and weight loss in somebody with tobacco use. Recent COVID diagnosis could be things that put somebody into a prothrombotic state. So it's still, even though, it wouldn't really explain the neutrophilic leukocytosis up to 23. Like a CT of the chest, I probably would do it with do the study to rule out pulmonary embolism while I'm at it. Even, and it's not the very best to look at airspace disease itself, but I think that would be, just given the echo findings, would be high on my list to do. But yeah, what do you think, Vale?
Yeah, I think well, I'm trying to find what are the blind spots that all the imaging we have thus far could miss. And I think the myocardium is one that comes to mind. I don't know if the patient is stable at this point, but for myocarditis, I probably will start treatment before getting it, but I would entertain maybe a cardiac MRI to see if there's contrast enhancement on the wall, and that could be another point towards myocarditis. But yeah, I totally agree. I think we are kind of getting closer and closer with all the work that we're getting. So yeah, I'm on the edge of my seat to see what this turns out to be.
Yeah, great. I'll echo. I love where your head's at with with the possibility of myocarditis. We have our coronaries are clean. What could cause some problems? So they didn't really have if we had EF being low or wall motion abnormalities, other things that can kind of cause those problems with clean coronaries are Minoka, vasospasm, Takatsubos, but I'm not really hearing the classic echo description for any of these diagnoses. So yeah, I think I would be reaching to take PE off the table, and then working with the theory that you said with the myocarditis, which could be viral in nature related to recent COVID. I think that's all I got for now.
Okay, very good discussion so far. Yeah, exactly what I was thinking when going through this case, or when this case was presented to me. I think, John, you were mentioning getting a CAT scan. So let me put up the CAT scan, or a segment of the CAT scan. You want to take a few minutes to look at it?
Yeah. So I think my attention is definitely drawn to the esophagus. There's some hypertensity in the lumen of the esophagus and what looks like a crescent of air. It looks like it's potentially outside the esophageal lumen there. I can't quite tell for sure, but we certainly raise and when I see that, certainly brings concern for the possibility of cancer or even like a small, like contained esophageal perforation. I don't see, there's no pleural, usually there's no pleural effusions. And it's, if you were going to talk about that, ruling that out, it would be hard to do without a oral contrasted study. Yeah, anyone else like either in the chat or seeing something I'm not?
Not for me. I totally agree. The esophagus, man, is always the sneaky one.
Yeah, very good. So that really stuck out. As you see, there is something weird happening in that esophagus. So, John, that PE I thought was an excellent idea. So no PE was identified. The lower cut did show extensive right lower lobe pneumonia developing. A very small, the intensity of this CT is kind of bright. So there is this here is a effusion. It's very hard to see, but there is an effusion developing there as well. And there's thick distal esophageal wall suspicious for malignancy. And I'll stop there if you have any thoughts.
Yeah, I mean, I'm not really sure. I think, I mean, as John mentioned early on, I think this probably has been going on for longer than the acute presentation the patient is went for to the ED for. So the dysphagia could account for like these esophageal wall changes. And then, but I do think that the acute presentation could be related to maybe the lung findings on the pneumonia. So kind of like, I think I would like maybe to say that there's some component of immunosuppression in this patient with a cancer background. I'm not really sure exactly what other like complications from esophageal malignancy can occur beyond like a rupture. But yeah, we'll have to learn from you, John.
So I think the possibility of esophageal cancer was something we were kind of from the start we were framing like as a person with tobacco use history, with progressive dysphagia and weight loss. So I had that as kind of a possibility that we were entertaining. And it's one was like, is this separate or was this a vulnerability that led to something bad happening with the COVID infection? So happy to hear like that PE, acute coronary syndrome, these things are ruled out. The white count, still like the white count's quite high for somebody like with a pneumonia that you see on a CT, but not on an X-ray. And that I'm still bothered by that little like rim of air that I'm not entirely sure is in the esophageal lumen, especially with you kind of pointing out that bright strip at the bottom was the pleural effusion. So I probably, well, if I'm taking care of this patient, I'd have him on some broad spectrum antibiotics to start to cover for pneumonia. And I would either get like a repeat CT with oral contrast or a barium swallow to get a better idea about the esophagus and whether that needs more more urgent attention or will need a more routine endoscopy when the patient's more is like had some antibiotics and is more stable. I think that's the last like urgent test I might do in the moment here.
Yeah, absolutely wonderful thoughts. Yeah, your sequence of diagnostic imaging or testing is on par. Like is right on point. I think the next test I'm going to show you, or the next image, will be a barium esophagogram. Bear with me a second. Okay, I'll give you a minute if you want to take a look and if you're able to point out anything.
Yeah. So I don't look at these often, but I'll say I can see the signs of obstruction. You know, as the contrast is trying to make its way down, there's a narrowing. And what I see, like in a couple of the images, is what's at least concerning to my untrained eye of some possible contrast extravasation out of the esophagus into a nearby anatomy there. So I'd say, like, I see this, I'd ask what radiology thinks. I would call up my friendly thoracic surgeon to take a look at this. Yeah, what else? Anyone else? What others thinking?
Yeah, and what it strikes me a little bit is that it's quite multifocal, at least to my eye. Like it seems like in the second image we have one narrowing and then a little bit lower, another one. So I mean, I wonder if that's typical of esophageal cancer, or if I'm like even reading the image correctly. But yeah, I think probably we will need a biopsy to see, and then some like imaging of the rest of the body to stage if this is cancer.
Yeah, I think like the tobacco history, like, yeah, I agree, very concerning for cancer. So like the kind of the urgent thing I wonder is even before like a biopsy, getting pathology is like, if this is what looks like the contrast leaving in some place where it's not supposed to be there, they may need like an esophageal stent to kind of protect the patient in the meantime too. And I wonder, like, how do I directly relate this to the like troponin of 1800 and the diffuse ST elevations? Suppose they are neighbors in the mediastinum. So this inflammation surrounding a possible contained perforation could perhaps be making the heart unhappy.
Great read of this. Yeah, esophagograms I don't usually read, but you can kind of see the tapering off of the contrast going through the esophagus. And you're absolutely right. Do you see my cursor? You see this branching off on the lower right-hand side image. This is branching off. So that's showing there's extravasation of contrast into the region of the right lower lobe, and that's where the right lower lobe pneumonia and the diminished breath sounds emanated from. And also then the pleural effusion developing on that right side as well. And there is a large irregular mass mid to distal esophagus with this extravasation. So, oh, sorry, don't share. So with this, the patient, if we go through the sequence of events, the patient came in with all these findings and having the dysphagia for about a month, weight loss. So kind of a signal for inflammation / malignancy. The AFib with RVR was I guess, is as a downstream effect of the stress on the patient and the heart rate being up in the 200s, but what came under control probably was a reason for the troponin release. And troponin release was kind of generous and overrepresented, but the cath was clean. And the white count was due to that right lower lobe infiltrate that was developing. So further evaluation resulted in this esophagram. There was esophageal pulmonary fistula, and with biopsy of this obstructive mass with the endoscopy, poorly differentiated SCC with extensive necrosis. And then the patient was started on chemotherapy and with follow-up with oncology. Any reflections on the case?
This is amazing, Ravi. And thank you, John, for guiding me through this case. I think my main reflection is to never forget about the esophagus, because it's one of those sneaky structures that always surprise me. And yeah, I mean, that's my main reflection. What do you think, John?
Well, I'm excited to hear about the the diagnosis for the patient, but hopefully you know, if they don't have a lot of metastatic disease elsewhere, end up, you know, getting chemotherapy, but you know, whether they could be a surgical candidate with like a esophagectomy down the road. He's a relatively young guy without a lot of comorbidities. But after kind of reflecting on patient, and I think that the journey was a interesting one. We first came like with this, you know, chest pain, ruling out the life-threatening causes, and with our 4+2+2, it actually kind of ended up being, you know, due to one of the like esophageal perf leading to pneumonia. So we had this COVID, you know, esophageal cancer brewing in the background that probably made the person vulnerable to, you know, coughing, developing a like this perforation that led to storm of inflammation with AFib with RVR and the profound white count leading to this. So yeah, great. Thanks for sharing the case. Hope the patient does okay with chemo and everything going forward. Anyone else have any reflections?
Yeah, I just want to mention, yeah, from the get-go, Vale used the 4+2+2, like John said. It really does pay dividends, and it did help direct you there. Usually the esophageal, the two esophageal, we don't really see many cases on when we have chest pain. But what's interesting, he didn't smoke cigarettes, but he smoked cigars, and typically you don't inhale cigar smoke, but I guess some can. But I guess with a combination with alcohol, usually oropharyngeal, but this was esophageal. But I'll have to look at I don't know off the top of my head, the risk with cigar smoking and esophageal cancer.
I didn't even like notice the relatively short duration of the tobacco smoking there. So perhaps I was overthinking the smoking history, but certainly I guess even non-smokers can be unlucky and have this happen.
Okay, we'll send it over to Eugene for teaching points.
Yeah, sorry, one quick question I'll highlight what like Richard asked. Like, did they think that was the ST elevations and all the kind of the cardiac issues due to like basically mediastinitis from the perf, basically making the heart angry from all the inflammation around it, or be the I'm favoring that over like a COVID viral myocarditis.
Yeah, no, the EF was normal. So with myocarditis, you would anticipate the EF sync being low. In his case, the EF was higher, LVH, and yeah, likely due to transient inflammation with all of the noisy stuff surrounding the heart. And then the AFib with RVR exacerbating the troponin release. Okay, back to Eugene for teaching points.
Okay, thank you. This was a very fascinating case of a 58-year-old man who came in with chest pain and then shortness of breath. So he described his chest pain as substernal, that's midline and crashing, but non-radiating. So we were able to start by localizing where this chest pain could be originating from. It could be from the heart, it could be from the lungs, pleural, it could be from the pericardium, also could be from structures in the mediastinum. And we also thought about the esophagus as well. And then the physiology behind this chest pain could have been ischemia, inflammatory cause, or obstructive cause. So we thought about myocardial infarction, we thought about infections, we thought about anything that could make, could cause inflammation. And then also the obstructive causes, we're thinking about the pulmonary embolism, also, some valvular issues. Then we took the shortness of breath as well. Shortness of breath being the patient either feeling breathless or a sort of hypoxemia. So what could be causing it? We also localized it to the lungs or the heart. And then we got some associated findings where the patient had cough for some days and also had COVID. So we thought about COVID being a possible cause of precipitating a prothrombotic state. So we thought that could link to a pulmonary embolism. And then this cough was also thought of to be, could have been from a viral infection that had led to probably some form of myocarditis or pericarditis. That's why this patient is presenting with the chest pain and then the shortness of breath. Then we had some more data with the history of with the family history, social history, and then health-related behavior, where we got to know that he had been drinking a lot of alcohol for a long time and also had been smoking cigar for some period of time. Another set of findings that helped us with this case was the dysphagia and the weight loss. So dysphagia actually brought our minds to start thinking about aniosophageal or oropharyngeal cause, and the fact that this patient has some health-related behavior of alcohol and smoking. We could think about oropharyngeal malignancies or aniosophageal malignancies. And then the weight loss also supported that particular theory. Then we had some vitals and examination findings that actually really tripped our minds to start thinking of MI, but in the case it wasn't, because we had tachycardia with irregular heart rate, which was eventually atrial fibrillation. The explanation for that so far has been that this patient, eventually we got to know this patient had an esophageal, also a squamous cell carcinoma, esophageal malignancy. And we're thinking that maybe the fistula was led to some form of mediastinitis that led to this cytokine storm or affecting those structures in the mediastinum, so including the myocardium, the pericardium. And so this patient had the diffuse ST elevation, also probably that might have led to the extreme heart rates with irregular rhythm. And then, yeah, we also got some other things that took our minds clearly away from heart findings, but also we could explain a bit with the troponins being high at 1,760. We're thinking that that could just be as a result of the myocardial injury. So yeah, very fascinating case of esophageal cancer, squamous cell carcinoma, which affected the distal part of the esophagus. We're thinking could be as related to the cigar, but not so very confident with that, or even from the alcohol, which Dr. Ravi mentioned that is usually with oropharyngeal issues. And that led to a fistula, that led to mediastinitis, and that presented with these findings that we had. So that was a very wonderful case. This is where I'll stop with the teaching points.
All right.
Yeah,
Thank you,
over.
everybody. Go. Thank you, Eugene, for the teaching points. That was a wonderful summarization of everything that was discussed. Thank you, John and Vale. Wonderful discussion. You guys just nailed the DX, or the suspicion of DX in the initial few aliquots. So wonderful job. Have a great rest of the day. Take care, everybody. Bye.
Thanks. Bye, everybody.